That's really interesting. We'll move on to Anna now, who will bring us back to the ground when it comes to thinking about the pandemic. But I just want to put you on alert, Kevin. A number of people in the chat are wanting to bring up the sustainability issues related to pandemic responses, so we might get back to that. Anna.
Yes.
There you are. Would you like to share a screen, or would you like to speak without slides? Okay.
I'm going to share a screen just because I think visuals make this a little bit easier.
Okay. And if you would just take a couple of minutes while you're getting yourself set up to just get a little bit of your background, which is a pretty interesting and relevant one, and explain what you're doing, that would be great.
Sure. So, hi, everyone. I am Anna Muldoon. I am a doctoral student in the School for the Future of Innovation and Society. I am also a research professional at ASU. So COVID is actually exactly the kind of thing that I work on and have for most of my career. I have a master's in public health with a focus in health policy. And I have worked in and around infectious disease since 2009. So this is in fact exactly the thing I am and always have been interested in. I just sort of hoped it wouldn't be this bad when it came. So before I came to ASU, I spent nearly 10 years at the Department of Health and Human Services in the Assistant Secretary for Preparedness and Response, which works on preventing, well, exactly what we are experiencing right now. So I have been doing this for quite a long time. And with that, I am going to talk to you just a little bit about modeling and data and the complications of all of that in COVID. So, no, go over there. Sorry about that. There we go. So this is the most basic, these are two versions of the most basic form of a model, right? A model is just a representation of the progression of a disease. That's it. At least this type of model. So they can be incredibly simple. Someone doesn't have the disease, they're susceptible, they get infected and they're infectious, and then they recover. That's the basic version. Now, I suspect by now you guys all know that COVID has not been that kind to us and is a little bit more complicated with asymptomatic spread and pre-symptomatics. It's a bit more involved than that. So don't scream. I promise I'm not going to make you walk through this next slide. I promise. So this is where we ended up with our model, which is significantly more complicated than the very basic susceptible, exposed, infectious, recovered version. But this was necessary because the entire goal of modeling is to accommodate the progression of the disease. So COVID is a complicated one, right? It takes a while for, particularly in the early days, took quite a long time for cases to show up in testing. The asymptomatic spread versus pre-symptomatic spread were deeply unclear for the first many months. So the process of building this model was sort of definitely building the plane as we were flying it, but also was a process of constant change, constant rearrangement, constant searching of literature and the discovery of new information as we were attempting to build the thing in the middle of a crisis. So it requires a lot of brain-bending thinking around whatever disease you are dealing with. And I would say for most diseases, there's no such thing as a perfectly standard model that you don't have to adapt to fit the disease specifics. So I'm actually going to skip a couple of these. But just to prove the point of exactly how complicated building models, particularly for brand new disease, can be. This is the performance on, I think this one is national models, of a subset of the models that exist for COVID. And as you can see, some of them have done really well. Some of them did well for a while. Some of them have not done so well. And it's partly because everyone is trying different approaches, right? So everyone tries different approaches, and eventually people start to converge on methods of looking at what we think might happen that work. And this is just for entertainment, the same models, but ranked by how they performed on state level projections. Meaning, some of them got national really right and state really wrong, and some of them got state level really right and national really wrong. So that's where I'm gonna stop torturing you with slides that have a lot of numbers and a lot of diagrams and just talk to you. So at the beginning of this outbreak, we didn't know anything really about COVID. We learned pretty quickly that it was a coronavirus. We didn't really know how it was spreading. We, assumed that it had originated in Wuhan. Turns out probably was around before that, and that was just the first big event. So as we moved into the outbreak and moved into tracking local data and national data, everyone was kind of scrabbling around for every piece of information they could find. Every article that came out would immediately get picked up and discussed for whether it needed to adjust our probabilities inside the model, or what it told us about whether the structure of the disease dynamics we had built was right. And so as time has gone on, the ways that we approach all of these things has adjusted. Things have solidified a lot more, right? People are not still fighting about whether asymptomatics can transmit COVID. They can. We know this, but we didn't. 4 months ago, there was still debate. So it has changed incredibly rapidly. And it's a technology cycle basically that goes at light speed. And thankfully, is pretty cooperative, right? So people from a lot of universities talk to each other and share information and discuss their models and try to see whether they can help each other improve them, because the entire goal is simply to have some idea of where the disease is going and where it's taking us. So in order to talk to you about modeling, the second piece is actually the really basic ground truth data collection piece of this whole situation. Because all of these wonderful compartmental models that help us understand where we might be going can't function if we don't have good data. And in this pandemic, we have seen a lot of data issues that I don't think most of us really expected would be as much of a problem as they are. I am very sure that there were some people who expected this, because there always are, but I think most of us did not think that we would have this much difficulty even knowing how many cases there are in a given place. And that has been a collision of factors, right? That it took so long to spin up testing, that many people were using different tests for a long time, that some were better than others. And then, of course, issues with data collection and data reporting, that for a while, not everyone was reporting the same data. Not everyone was reporting data the same way. And there have been moments when different states are actually using different case definitions for what's a confirmed case and what's a probable case. So it makes actually working with the data, the very data itself, that is the ground truth you need to do all of this work, to track, to understand the demographics, to understand how fast it's spreading, how it's spreading, who is most at risk, and then from there, hopefully, to also build some projections that give you an idea where you're going. That ground truth data is the base for all of it. And when there are problems with the ground truth data, it starts getting a little bit interesting. So we've spent a lot of the past 9 months, by we, I don't just mean my team, I think I mean the public health community possibly as a whole, dealing with things that probably most of us would assume that in this world of interconnected technology and rapid communication wouldn't be problems, right? Making sure that we can all get clean data that's comparable across states. Like globally, that's even harder. And the bigger you go, the harder the problem is. And the more complicated the approach is to try to make sure we have good data that can be worked with, that really does lead us to the right conclusions about what's happening, can be. So, you know, Bob posted the Johns Hopkins website that has the beautiful map. When they got that website up magically fast. It was amazing. It was the early days when, you know, we didn't even really know where COVID had gone. It was not yet called COVID or SARS coronavirus 2. It was still just the novel coronavirus. And it started popping up in tiny spots, and the map watched it spread. I kind of hope somebody has daily screenshots that they can turn into a video as it spread across the world. I am very sure somebody does. But that map and the data that was coming in on it became a crucial point for a lot of us in the early days, when information was not very available, when everything was changing incredibly quickly. Those kinds of public projects that compiled data, that got data out there where everyone could see it, were a crucial piece of coronavirus response, and I think a very good example of public interest technology. That is exactly the ways that we would all hope we could use our technology, our data, and our energy to get information out there in the middle of an outbreak. So I think it's also worth noting that we now see everyone creating COVID trackers, right? The New York Times has one, the Washington Post, Hopkins. I could not list them all in the time we have available. And they're all similar, right? But everyone takes their own tiny slant on how they want to look at the data. We have some standard measures that most places report, you know, the number of cases, the number of deaths, the number of hospitalizations, the number of tests, the percent positivity. These have become standard measures that people, I think for the most part at this point, understand at least what trends in them mean. Most, I think, public health people never actually thought we would be discussing the differences between RT and R naught in public, well, ever, but that has also become a joyful activity. And so those trackers are another kind of example of how the obsession and the use of public technology has really created this crazy amount of information that is mostly the same information, but Not quite. And the digging through it gets really complicated. So there are so many other things that I could talk about that have happened with data and modeling and epidemiology in this moment. But I think I'm going to pause there so that you guys have time for questions. Unless, Elisa, you'd like me to keep going.
Actually, I think this is a really an interesting place to stop, because what Kat is going to be talking about is some of those surveillance approaches, which are a different way of thinking about using that data, right? When we get to the Q&A, one of the things that I'd like to sort of have you tuck in the back of your mind are some of the analogs to some of the things that Kevin talked about, but in terms of data. So he talked in terms of supply chain 101, and like once you know the answer, it's good to centralize it, right? You didn't address, but we can talk about it, during the Q&A, whether the kind of data standardization issues, the kinds of problems that you're talking about, whether they're normal or whether they're somehow worse in this particular case because of the disaggregation of how testing is being done, kind of like across so many different parties that therefore will have different, procedures. So I don't know if you wanted to comment on that now, or if you want to just kind of hold on to that.
Sure, I'll make a quick comment on that now, and if people want to follow up, we can do that. I think that it is guaranteed that in any outbreak, particularly one that moves this fast, there will be data issues and there will be conflicts about data collection and case definitions and test sensitivity and specificity, right? We've seen all of these things. And there will always be fights about data interpretation. I am not actually convinced that centralized data solves all of the problems, because some of the problems are just ground truth problems in how working in this kind of incredibly rapidly shifting landscape of disease goes. It's always unpredictable, it's always changing, right? So I think to some extent those problems can be solved with better communication, but the things that are simply a facet of infectious disease, and particularly emerging infectious diseases, they just are what they are, and I'm not sure that those will change in any outbreak ever. They've been the same forever, and I think they will stay the same.
Well, that's great, because now Kat can help us understand how the different methods that people are using for surveillance just iron out all of these data problems so that we can have full confidence in what they tell us, right?